your heart will have beat 36,300,000 beats. This is amazing. Always working, never stop, or most of the time working in the right way. The average, as you are young people, the average age that you have expectation to live is around 80 years. It means that when you arrive at your 80 years, I won't be there at that time. When you arrive at 80 years, your heart will have beat 3,000 millions of beats. That is an amazing number. 3,000 billions of beats. If you consider that each beat pushes around 70 milliliters of blood to the general circulation, when you arrive at your 80s, the heart will have pumped more than 200 millions of liters of blood to the general circulation. 200 millions of liters. Take into account, as a comparison, that is an Olympic swimming pool has around 4 million of liters of water. Then you can understand what is an amazing activity of the heart. And also you have to consider that sometimes the heart has some problem, and this is the moment when all of you will participate to solve the problem of the heart and to recover the healthy condition. In any book,
Recording in progress.
okay, in any book, we can see some schematic image of the sinus node. That is a small structure in the upper part of the right atrial, very close to the superior vena cava. This is a schematic idea. If we move to a more realistic image, you will see that this sinus node is an irregular structure and start in the union of the right atrial and superior vena cava, but extends toward the bottom part of the atrial, very close to the inferior vena cava. This is the real sinus node. Moreover, around the sinus node, there is another structure that is the paranodal sinus, which have cells that also can maintain the heart rhythm. And all these structures are promoting sinus rhythm. It's not only this small structure, it's a more important structure. Sometimes the cells that command the sinus node is moving along this structure and in the paranodal area. And you will see it in the electrocardiogram, because you will see what we call the wandering pacemaker. It means that you will see different shape and size of P waves along the time. That in this case is moving, is more flat here, is negative here, and this is part of this movement and of different cells that are participating of the sinus rhythm. The question is this wandering pacemaker normal? The answer is yes, it's physiological, it's normal. And if I start any exercise, probably will disappear, and the classical P wave will appear, because it's related with the upper part of the sinus node. Is it clear?
Yeah.
I can hear you, but you can raise your hand if you believe that it's clear. Okay, now I understand. Another condition that I want to re-emphasize, to stress, is that the sinus node has its own artery who perfuse the sinus node, but in the upper part of the sinus node, maybe around here. Now it's time to remember that the innervation of the heart are coming from the autonomic nervous system, sympathetic and parasympathetic, that is represented by the vagus nerve. The sympathetic always is around the artery. If you can find sympathetic tissue, look around the artery, because the sympathetic tissue is always accompanying the arteries. Then I will find sympathetic innervation of the sinus node around the upper part of the sinus node. This is the most common view. On the other hand, the vagus nerve has influence in the entire sinus node. Once again, the parasympathetic show innervation in the sinoatrial node and the AV node. The sympathetic show innervation once again in the sinus node, but in the upper part, in the AV node and in the ventricle. This is another important difference. You have sympathetic innervation in the entire heart, in the whole heart, but only parasympathetic innervation in the atria. Is this important? Yes, and we will see it later. And finally, this is the real image of the sinus node. As you can see, it's not so elegant like here. It's irregular, and his size is more than we have expected, and the borders are not very clear. This is the real image of the sinus node. When we consider, once again, the sinus node, we must take into consideration that it's an epicardial structure. It means that it's in the epicardial part of the heart. That's the reason, because when any patient suffers pericarditis, the influence of the pericarditis promotes a lot of arrhythmias in the atria. It's because the sinus node is in the epicardium. There are two kinds of cells in the sinus node: the P cells and the T cells. It means pacemaker cells and transitional cells. That is limiting. Transitional cells are in the border of the sinus node, and it's the limit in between the muscle tissue of the atria and the pacemaker tissue. Then, once again, the limit is the transitional cells. When you develop some kind of disease, what we call sick sinus syndrome, you could be affection of the P cells, and you will find bradycardia, or you will find some kind of premature atrial contraction inside the pacemaker cells, or there are any kind of difficulties that is associated with the transitional cells, that is blocking the stimuli from the P cells of the sinus node to the rest of the atria. This transitional cells can provoke some block that look like the AV block. The first degree, second degree went back or Moritz 2 and third degree. The same structure appear here in what we call the sinoatrial block. Then you can see first degree that you can see is difficult because you will see always the P wave following by the QRS normally. You don't know that it's a disturbance in between the beginning of the stimulating the sinus node and the time that they take to reach the P or the atria. What we can see if you have a second degree, because you can see there is a delay of the P until a P wave is blocked. This is a went back, sinoatrial went back. Or you can see that suddenly a P wave is blocked. This is a Moritz 2, not in the AV node, but in the sinoatrial position. And finally, transitional cells can block completely all the sinus node stimuli, and you will get this third degree sinoatrial block. Then, when you have some disturbances, also it's important to know if these disturbances appear in the P cells itself or if it is related to the transitional cells. Is it clear?
Yeah.
Yeah? Only one right behind. What happened with the pressure? Okay. In the conduction system, there are two kinds of cells. Cells that are dependent on calcium for the depolarization, and cells who are dependent on the sodium for depolarization. Which is the difference? That the calcium cells have the possibility, the property of self-depolarization, instead of the sodium cells that need an external stimuli to process the depolarization process. Then it means that the phase 4 is stable in the sodium cells and unstable in the calcium cells. At the beginning is a low influx of sodium until arrive to the threshold less 40, and the depolarization process takes place. Then once again, take a look about these two differences. Calcium cells, self-depolarization process, and unstable phase 4. While in the sodium cells is a stable phase 4, need an external stimuli to process the depolarization action potential. Once again, take a look that this start less 60, and when they arrive at less 40, is a faster influx of calcium, mainly calcium, but also sodium, but mainly calcium. Take a look another condition, that is the refractory period. In the action potential of the pacemaker cells, it means cells that use calcium for the depolarization process. The refractory period is not dependent on the voltage, it's dependent on the time. We need some time, 300 milliseconds, to be ready for the next contraction. While in the rest of the cells, the sodium cells, with a stable phase 4 that is around less 90, when external stimuli appear, the action potential develop, and the patient has a refractory period that look like or last around 300 milliseconds, but it's depending of the voltage. Here is depending of the time. Here is depending of the voltage. These are the main differences. Where we can find these kind of cells? Okay, calcium cells. You will find calcium cells mainly in the sinus node and in the AV node. In the rest of the cells that are sodium cells, you will see a stable phase 4 without possibility of self-depolarization process in normal conditions. The other difference is related to the refractory period. As I have already mentioned for you, the refractory period in calcium cells is depending on time, but in the rest of the cell is depending on voltage. And take a look what happened here. There are different duration of the refractory period in the different tissues of the heart. In the Purkinje fever is the more prolonged action potential. And in the muscle, in the epicardial muscle is shorter than in the endocardial muscle. And take a look about the atrial. It's really a very short refractory period. Is this good? I'm afraid no. But we will talk about this later. Moving on, once again, I want to re-emphasize once again that the parasympathetic nerves act only in the atria, and the sinus and the sympathetic system, the sympathetic autonomic nervous system act in the atrium and also in the ventricle. There are no parasympathetic activity in the ventricle. What these sympathetic and parasympathetic nerves provoke in the heart, promote in the heart. The sympathetic, chronotropic, increased heart rate. Dromotropic, faster conduction through the AV node. Henotropic, increased contractility. And lucitropic, faster relaxation after contraction. These are all the properties of the sympathetic innervation. And what about the parasympathetic innervation? Well, take a look, it's only one. Negative chronotropic. It means decreased heart rate. Sympathetic, increased heart rate. Parasympathetic, decreased heart rate. Once again, take a look about the innervation. There are sympathetic innervation in the entire heart and only parasympathetic innervation in the atrium. And you know that parasympathetic, shorter the refractory period of the action potential. It means that if you have influence of the parasympathetic in the atrial, it's the only place where you can find parasympathetic innervation, you will get a more shorter refractory period. And remember that in fact was shorter. It was a short refractory period, but would be shorter by the influence of the nervous value or parasympathetic. Then, if you have a very shorter refractory period, the possibility to develop arrhythmias increase. And that's one reason, because you have very often you can see atrial fibrillation, but fortunately, it's very improbable that you will see ventricular fibrillation. It means that as we don't have this influence, negative influence in the ventricle, it's a way to protect the ventricle from the ventricular fibrillation. Under physiological condition, the ventricle is protected by the existence of only sympathetic activity and no parasympathetic activity in the ventricle. Is it clear for all of you? Okay, perfect. This is the time to ask you something, because all of you raise your hand, meaning that you understood everything that I have explained. Now it's time for me to ask you. I have in the sinus node the parasympathetic influence and the sympathetic influence. If I try to, what happens? If I leave the heart without any influence of the autonomic nervous system, if I cut the parasympathetic and if I cut the sympathetic innervation, what happens in the heart? What do you believe that is going to happen? The patient dies. The patient develops tachycardia. The patient develops bradycardia. Nothing changed. What is going to happen?
Tachycardia will happen. Good
Tachycardia will happen. Is this the opinion of all of you?
Yes. They were flowers.
Oh, fantastic. Let me show you what is my opinion.
Yes.
Okay, it means that under physiological circumstances, the predominant effect in the sinus node is the parasympathetic effect, except when you are performing exercises. If not, the predominant effect is, as you have already mentioned, tachycardia. Okay, now we are moving to the internodal tracts, briefly, but just to know something about it. There are two models in the different books and papers and journals. You can find this one with internodal tracts connecting right and left atrium, connecting sinus node with the AV node by means of three intertracts nodals, or this model without any connection, and the stimuli moves freely in the muscle, in the atrial muscle, reaching the left atrium, reaching the AV node, and continues to the ventricle. These two models has been discussed for many years because there are no agreement among all the physiologists about which is the role of internodal tracts. What we can say nowadays, well, there are no doubts, anatomically exists a connection in between sinus nodes and AV nodes that are the internodal tracts, yes. The point is, are they active or they are only anatomical structure without function? What we can say is that anatomically exists, but we don't know, and we believe that have no physiological function. In fact, which are these trucks? What are made of the trucks? They are Purkinje-like. It means myofibrillar poor. That is a classical condition of the Purkinje neck, which ensures that the action potential arrive at the AV node at an appropriate time. Yes, but at the same time arrive through the common muscle of the atrium. Then it's not working in the physiological field, but exists anatomically. One of the most important point against the activity or the utility of the internodal tract is that it's different from the His bundle, because the His bundle is a real cable. It's a cable because you have a tissue that is covered by fibrous tissue. But the internodal tract has no covering at all. There are no insulation of the tracts. It means that in a very close contact, free contact with the rest of the muscle of the atria. There is no advantages to be an internodal tract. You can move faster, you cannot move faster, because you have no insulation related to the rest of the tissue. And when you move to the ventricle, the situation is completely different, because this tissue is covered by fibrous tissue, like any cable that you have at home, for the TV or whatever. It means that the cable is covered and protect the velocity and the displacement of the depolarization wave from the AV node until right to the ventricular mass. This is a difference, an important difference in between. In summary, the internal tracts are actually preferential pathway, muscle tissue with some specialization, not comparable to the Purkinje fibers. However, there is a particular exception. That is the Bachmann bundle. The Bachmann bundle connects the right atrium with the left atrium, right? And really has a physiological function. In fact, the Bachmann bundle has an action potential that is different from the common muscle. It's more important, the deflection, and is more prolonged, the refractory period. But what I want to concentrate is in the activity of the Bachmann, because if you have a normal electrocardiogram, you can see this kind of P wave in DB2. But if you have a Bachmann block, you will see this P wave, positive at the beginning, later negative. This wave is a typical of the patient who has a block of the Bachmann bundle from the right to the left ventricle. And why is positive at the beginning and later is negative? Because you need to, as you are blocked, you cannot reach the left atrium. You need to move to the AV node and by retrograde way arrive later to the left atrium. And then this is a positive part and this is a negative part of the P wave, like you can see here. When you see this kind of disturbances, you will see in the inferior leads of the electrocardiogram, meaning P3, ABF, and P2, this typical positive, negative P wave, positive, negative. Is it important? Yes, it's part of the what we call Bajes syndrome. And Bajes syndrome is related with more possibilities of atrial fibrillation and as a consequence, thromboembolic episodes. It means that we should recognize when we see the Bajes syndrome. And we have to take care of this patient because they can develop this kind of complication. It's clear for everybody is? Yeah? Okay. Okay. Now we are moving to the AD node. Let me show you this picture.
Please, I have a question, please.
Yeah.
In case of, there is three connections between atria, the coronary sinus, the fossa ovale, and the Bachmann bundle. In case,
Yeah.
so in case of block of the Bachmann, the other connection can replace the Bachmann, can compensate this block. So we can have, is it sine qua non to have this pattern of atrial depolarization in case of Bachmann block?
Yeah, this is the image that we can see here. It's a typical image of the Bachmann block. Positive, negative in the three leads of the inferior electrocardiogram, inferior wall of the electrocardiogram. That was the question?
No.
No.
If we have
Okay. Try again. I will do that. Because maybe I can hear you clearly. Let me see.
in case of Bachmann.
Just one second.
Wala gamer.
Okay, again.
In case of the Bachmann block,
Yeah.
there is an alternative. There is the coronary sinus, and there are other ways. There is the coronary sinus and the fossa ovale. To have this large P wave.
Yeah, but if I understood your question is, if you have an increase in the size of the P wave, because an increase in the size of the left atria, for instance, that was the question?
No, we have
No.
we have three internodal connection: the coronary sinus, the fossa ovale, and the Bachmann.
Dr. Raul,
Yeah.
the thing is, Bachmann bundle it's not a persistent structure. It's not exist in kind of 20 to 30% of patients. So we have other structure that can conduct from the right atrium to left atrium, which are usually the fossa ovalis, coronary sinus, and in some percent of patients, it's the posterior part of the right atrium. So in these patients, who they don't have Bachmann bundle, this pattern of the surface ECG is still valid or not? This is the question.
I understand. Now I understand. Now, this is a very difficult to discuss, because most of the time when we are performing, for instance, electrophysiological study or performing ablation in the left side and in the left atria, sometimes we cannot recognize Bachmann, but it still is there. The point is how I can emphasize, how I can be sure that there are no Bachmann bundles. Inclusive, they have its own coronary artery. The artery of Condorelli has been described by this Italian electrophysiologist many years ago. Then, for me, it's not so easy to say, no, sometimes there are no Bachmann fascicles or fiber. I believe that not always it's easy to confirm that there are no. Maybe I cannot recognize. If I show you, and probably you have done this, if you open any heart and you try to recognize the internodal tracts, probably you can find any internodal tract. It's not easy. then I'm not so sure that we can say very firm that there are cases that it not exist in Bachmann bundle. I believe that sometimes we cannot investigate deeper to recognize the Bachmann, but it's just a position.
Yes, in some EP studies, the thing is that Bachmann bundle can be indirectly diagnosed with depolarization in the ostium and distal coronary sinus at the same time, and the late is the mid coronary sinus. This is the way that Bachmann bundle can exist in the EP study, but in some patients there is not this delay between, there is a delay actually between the ostium of the coronary sinus and the distal coronary sinus with the downstairs depolarization. So in these patients, 15 to 20% of patients, there exists this downstairs depolarization in the EP study. So in these patients, the Bachmann bundle don't exist in some speculations.
Yeah, I understand. Could be. I can opposite and the possibility that could be present, I would say, in 20%. Probably is true. Probably some research, some published papers approve the no existence of Bachmann bundle. Could be, yeah, could be. It's a possibility. But however, how many times will you recognize the Paget syndrome? This is a question. How many times we recognize the Paget syndrome? For the complication of Paget syndrome, taking into account that 10, 20 years ago.
For me, I didn't see it.
No, we don't pay really don't pay attention for this conduction abnormality. Now, when you describe the P-wave morphology, we will perhaps see this morphology more frequently.
I believe that it's more frequent than we can imagine. The point is if we are prepared to recognize it. Once we started to analyze this pattern, and we are going back, at least for instance in my hospital, in the university, to review hundreds of electrocardiograms, we discovered some of them that we never thought at those days that we are facing a syndrome with some complications like atrial fibrillation or thromboembolic episodes. Nowadays, everybody in my hospital, in any part, is aware of the possibility that this kind of syndrome could be present and the possible complication. That was the reason because I wanted to mention this one. Okay, it's interesting, but we need to continue. We are moving now to the AV node. When we are talking about the AV node, first of all, we need to explain that most of the connection, the unique connection in between the atria and the ventricle is through the AV node and his family, because the rest of the fibrous tissue acts as an isolation of the cell's activity in the atria and the cell's activity in the ventricle. This is the only way in a normal condition. We know the accessory pathway, of course, but it's not a normal condition. And the normal condition, this is the unique way that you can use to reach the cellular activity of the atrial and the impulse of the atrial that arrive to the ventricle. Also, all the epicardial structures contain, once again, fibrous elements that help to the isolation of the ventricle from the atria. The epicardium is contiguous with the insulation fibrous tissues of the fibrous artery. It means that it's just one structure and it's a complete isolation. It means that all the contact all the stimuli that start in the sinus node must cross the AV node to reach the ventricle. There are no other normal conduction system. And help, of course, to separate atrial myocardium from myocardium. What is the atrial node? All of you know, or probably that is in the Koch triangle, that is the coronary sinus, the tendon of Todaro, and the septal leaflet of the tricuspid valve. This is the place where we can find the AV node. And this AV node that is here has a two different parts. One is faster than the other, and continues with the penetrating part of the His bundle that is inside of the fibrous tissue, and later appear in the ventricle and offer the two branches, left and right branch, to continue the stimuli until arrive to the Purkinje neck. This is the common structure that I guess all of you know perfectly well, without doubt. And this is the structure I want to analyze with you. This is the two parts in the inside of the central fibrous tissue and in the membrane septum. This is the two parts of the His. AV node, His in the penetrating His or in the central fibrous tissue, and in the membrane septum where appear the division of the left and the right bundle. Once again, we can see the two parts of the AV node, one is faster than the other, and continues with the His bundle and the division of the His bundle. Now we are moving to the His bundle. And this is the moment when we ask ourselves, how are the stimuli, the electrical stimuli are connecting, how they are connecting one cell with the other cells, which is the normal way. And the normal way is through a connexin, that is a protein that connects two cells through the gap junction. It means that the electrical stimuli move through this protein to reach from one cell to the other cell to promote a faster transmission of the electrical stimuli from one cell to the other. This is another view where we can see, once again, from one cell to the other through this gap junction channel that we call connexin. It's a protein, and there are different kinds of proteins depending on the different part of the system. We have at least 3 connexins. There are many, but there are 3 main connexins that are important for us to recognize. We have connexin 45, that is for is a very slow conduction system, and you can see this in the sinus node and in the AV node. This is a connexin 40, that is for a very fast conduction, and you can see some in the atrial, in the His, and in the branches, and Purkinje. And it's a connexin 43 that is in the union of the Purkinje neck and the common muscle, in a specific muscle of the ventricle. Then we have 45, 40, and 43. There are different velocity of conduction. In the AV node, where we have connexin 45, the conduction is 0.05 meters by second. When we move to a faster way, this is His and His Purkinje neck, The velocity promoted by the connexin 40 is around 3 to 4 meters by second. And when you arrive in the connection in between the Purkinje net and the inespecific muscle, the connexin 43, the velocity of conduction is 1 to 2 meters by second. As you can recognize, there are different velocities according to the needs. Of course, in the AV node, we need some delay. We need it for two main reasons. The first is because the electricity is moving faster than the mechanical. Then, once the stimuli arrive, I need some time to give the opportunity to the mechanical contraction on time. And the second one is that, as we have proved that many fast arrhythmias could appear in the atrium, one way to protect the ventricle is specifically the AV node, and because the AV node has connexin 45 with a very slow conduction, then most of the stimuli in the presence of an arrhythmia will be blocked here, protecting the activity of the ventricle. Then, once again, in the sinus node and AV node 45 connexin, in the East bundle branches and Purkinje 40, and in the union of Purkinje and in a specific muscle 43. There are the three main connexin. There are a lot of connexin, but these three are the most important connexin to explain the behavior of the electricity among the connection of the electrical system of the heart. Once again, this is a penetrating, and this is in the post-penetrating in the septum, previous to the division in the right and left branch. The other interesting point that was discovered, we can say recently in the last 10 years, but was proposed in the 70s of the last century, was that inside his bundle is a preconfiguration of the fibers that will end in the left or will end in the right. Like it is a lot of cables here with different colors that will end in one part just inside his bundle. You know that this will finish in the left and this will finish in the right. This is a very important instrument because it's a support to our techniques that nowadays we are applying related to his bundle stimulation or left bundle stimulation or different possibilities that we are developing nowadays related how to stimulate the heart when they have a block. But the other interesting point is that when we move to the bundle branches, right bundle branches, and left, we can see now that the right bundle has a particular structure. Start from the east and continues without division until the anterior papillary muscle. At that time, start the division. This is one of the conditions of the right bundle. But if we move to the left bundle, what we can see is that immediately after start from the east bundle appear a real net, and the division starts immediately after the beginning of the left bundle. And these two different positions need an explanation why they have this structure and why the right bundle has the other one. Maybe one of the explanations, this is a nature sometimes give us the opportunity. I found it in my garden, and I discovered that this is a kiss bundle. The right that at the end has division, and the left bundle that has a posterior division and anterior division immediately, and it's a neck. This is a simile in the nature what will happen inside the heart of all of us. And I was asking why is this structure here and why this is structure here? Well, one of the question is, once again you can see, this is a large bundle and at the end the division, and here immediately appear many divisions and a neck. Once again you can see a neck in the left bundle. Immediately is a neck with small divisions but cover the entire ventricle. Another vision of this division immediately appears. The left bundle is the division in a neck. Once again, in a neck. Look at the right. At the end is the division, but for the left bundle immediately appear divisions in a neck. If you want to try to understand why this difference, anatomical difference, maybe we can see that the pressure of the chambers are completely different, as you well know. Here, we have a maximum of 25, and here we have at least 100. According to Planck's law, the radio has a role in the world tension. That is what developed, and is a more radio, more world tension. Then, as we are acting in a chamber with low pressure, the fibers are not receiving a lot of stress. They don't need to change the shape because this pressure is very, very low. But in this chamber, in the left chamber, the pressure is very high, and is to protect the fibers. They have a very early division in many, and if they are small one, also the radio is small, also the wall tension is small, and they can be protected against the high pressure of the left chamber. This is the reason, because in the left side we have a neck from the very beginning, and in the right side we don't need it, and we have the division at the end of the right bundle in the anterior papillary muscle. Is it clear for you? Yeah? Okay. I move ahead. At the same time, if we return to our nature example, we can guess that if I ask you, what is more possible to get a complete left bundle branch block? A complete left bundle branch block. Probably it's more easy to get this in the east bundle with the pre-configuration of the fascicle, or at the beginning of the left bundle, because after it's a neck, and probably it's more difficult to break an entire neck to get a left bundle branch block. This is the reason, because most of the left bundle branch are proximal left bundle branch block. Fortunately, because now this situation gives us the opportunity to promote his bundle pacing. In this paper, you can see that most of the time, it means that 46% the bundle branch is inside the east, and in 18% is at the beginning of the left bundle, and is less often you can see in the distal part. It gives us then the possibility that in the two-thirds of the left bundle branch block is a proximal bundle branch, and you can correct it by means of the Higgs bundle base. This is an advantage when we learn about this disposition. This disposition gave us a tool to improve the situation of patients with left bundle branch block. Then, now we have the possibility to stimulate in the Higgs bundle, or at the beginning in what we call left bundle branch block area pacing in this part. That's what we are doing nowadays. And it means that we can correct, because most of the time left bundle branch block is a proximal block. Finally, we are moving into Purkinje net. Up to now, we see we have a review of all this conduction system. And atrial muscle, ventricle muscle, the connection in the atrial muscle in between sinus atrial node and AV node, and here at the end of the Purkinje fibers. Let me tell you that in the Purkinje fever also we can find this condition that we saw in the AV node and in the sinus node, the possibility of self-depolarization process. That is slower than here, but if I have a distal block, probably I will survive, because in the Purkinje fibers, some cells can promote self-depolarization, and with a very important bradycardia, still maintain my life. There is another condition that I want to re-emphasize. The Purkinje net is a fantastic net that appears and covers the entire muscle of the ventricle. And do we need it? The answer is yes, we need it. Why? Well, let me show you how is the net Purkinje. This is the endocardium, and very close to endocardium appear the Purkinje net that connect with the non-specific myocardium. Then the first concept is that the Purkinje is an endocardial net that connects the end of the electrophysiological system of the heart with the inespecific muscle. Now you can see here, there is the working myocardium, and in red you will recognize the 43 connexin that I told you some minutes ago, that is a connexin that, once again, still connect the end of the Purkinje network with the inespecific muscle. And the velocity of conduction is not as fast as in the Higgs and branches, but it is still a very interesting velocity. It's around 1 to 2 meters by second. If you see the right ventricle, take a look about the Purkinje, and in the left ventricle, once again, the Purkinje. It's a very expensive net. We need it? Yes, we need it. Why? Because there are an important difference in between muscle in the atrium and muscle in the ventricle. First of all, the size. Muscle in the atrium is about 10 to 12% of the total weight of the heart, while the rest is muscle of the ventricle, the ventricle, and particularly the left ventricle. And the other reason is because the electricity in the atrial moves along the wall. It means that if I put an electrode here, I will get this wave. But if I put inside the electrode, I will get the same wave because the electricity is moving parallel to the wall of the atrium. But if I move to the ventricle, the situation is completely different. The depolarization process moves from the endocardium to the epicardium. Then, if once again, if I put an electrode here, I will get this wave, but if I put an electrode outside, I will put this wave. Meaning that we need to move across the muscle. This is parallel to the muscle, across the muscle. Then, to cover the entire muscle, I need a net to arrive in just few milliseconds to the entire muscle of the ventricle. That is because we need a real net in the ventricle and it's not necessary in the atria. That is the main reason. And remember that 75% of the muscle in the ventricle belongs to the left ventricle. At the end of the day, the real pump of the heart is the left ventricle. That is the reason because I say to all my students at the university, if a lady tells you, I love you with all of my heart, you must ask immediately, including left ventricle. If the lady says yes, okay, this is what is important. Keep in the left ventricle, the rest is not very, very important. Okay? I believe that that was my last slide. I appreciate your attention, your participation. I expect that this will be helpful in some way, in some aspect. That was my intention. I expect that some
هي المنطقة بتاعه تخليك تتكلم معاه.
Thank you to all of you. You have any questions, any comments?
Merci beaucoup, Raoul. Très gentil. It was great. Thank you very much. We understand some aspects that biophysiological